Hey there, welcome back to my channel. I am Gia, your friendly family nurse practitioner. So today, I am thrilled to chat with you about a common concern in primary care, and that is palpitations. So I'll do my best to keep it simple. I know we're all busy and reviewing symptoms might not be ideal, but I hope this discussion sheds some light and helps you decide what to do next when your patient is complaining of palpitations. So let's dive in. So what are palpitations? So palpitations are sensations of a rapid, fluttering, or pounding heartbeat that a person may feel in their chest. They can be described as sensations of the heart skipping a beat or beating irregularly, and palpitations can be distressing to a patient. What are the common causes of palpitations? So I categorize them into two buckets: non-cardiac and cardiac causes. So the non-cardiac causes of palpitations include medications. So you're gonna wanna review the medications, thyroid disease, anemia. So you're gonna consider this if your patient is premenopausal and also has complaints of heavy menstrual cycle, anxiety, panic attacks, depression, seizures, pregnancy, and electrolyte imbalances. So these are the common medications that can cause palpitations. Your beta agonist, the albuterol inhaler, your steroids, your stimulants, QT prolonging medications such as antidepressants, antipsychotics, some antibiotics, some antiemetic, and some antiarrhythmic medications. And so let's move on to the cardiac causes of palpitations. Again, I categorize them into two buckets: life-threatening and not so life-threatening. So life-threatening is your ventricular tachycardia, and this is your polymorphic ventricular tachycardia. And so for the not so life-threatening, there's gonna be your PACs, your PVCs, atrial fibrillation, your atrial flutter, your SVT, and the pre-excitation or the Wolff-Parkinson-White syndrome. If your patient is coming in for palpitations, history is everything. So you want to know the timing. When do they happen? The onset. How often does the palpitation happen? In what situations? What time of the day? And how long do they last? And what are the triggers? What relieves them? And especially, you want to know any other associated symptoms. So what are the red flags that you have to consider for patients with palpitations? And so these are presyncope or syncope, any alteration in mental status, bladder or bowel control issues, and we are going to be worried about this with seizures, and any chest pain, any chest pressure, any edema in bilateral lower extremities, shortness of breath, and history of congenital heart disease or prior cardiac issues, and positive family history of cardiac events. And these are your unexplained sudden death, unexplained syncope, drowning, and the like. So your initial workup for patients with palpitation include your history, your physical and 12-lead EKG. And the labs that I usually order include CBC, your TSH, your BMP. I also add in MAG, urine drug screen if you're concerned about illicit drug use, urine HCG, and this depends upon your history and physical. So when will you start prioritizing the potential cardiac origins of your patient's palpitations? Recognizing the associated risk factors is crucial. So your risk factors include patients that are 50 years old and older, your diabetic patient, if they use tobacco, hyperlipidemia, or symptoms associated with syncope or pre-syncope. And the presence of these risk factors can guide you towards the next steps. So you can order an echocardiogram and or Holter monitor if you're concerned about structural heart disease. And you can determine this by your physical, right? If you hear murmurs, abnormal heart sounds, or if the patient has history of congenital heart disease. And then you can order stress tests and or Holter monitor if you're suspecting of ischemic heart disease, and this with presence of chest pain, chest pressure, shortness of breath. So on your 12-lead EKG, you want to evaluate for any irregular heart rhythm or extra beats. You want to look for atrial fibrillation, A-flutter, any PACs or PVCs. Look for any abnormal intervals such as your QT prolongation, any bundle branch blocks, delta waves, such as your WPW. And I want you to watch out for these red flags. And these are the Brugada pattern in V1 and V2 and epsilon wave at the end of QRS complex. So I want to talk a little bit about Brugada syndrome, although it is rare. So Brugada syndrome is primarily caused by genetic mutations that affect the normal function of sodium channels in the heart. And this mutation disrupts the flow of sodium ions in heart muscle cells, leading to an abnormal electrical activity and an increased risk of dangerous heart rhythms. While the exact triggers for arrhythmias in Brugada syndrome are not fully understood, certain factors such as fever, certain medications, and electrolyte imbalances may exacerbate symptoms in susceptible individuals. So the Brugada pattern on an EKG typically appears as a distinctive pattern in the right precordial lead. So I have here V1 and V2. It is characterized by ST segment elevation followed by a negative T wave, creating a coved or saddleback-shaped morphology. This pattern may be intermittent and can be exacerbated by certain factors or triggers such as fever, like I mentioned, or certain medications. Identification of the Brugada pattern on EKG can prompt further evaluation for Brugada syndrome, especially in individuals with a family history of sudden cardiac death or other risk factors. Does that make sense? And so there are 3 types here. And so I don't want to harp too much about them, but I just want to mention or introduce Brugada syndrome. So on the screen is an epsilon wave. So an epsilon wave is a small positive deflection seen at the end of the QRS complex on an EKG. It is a characteristic of arrhythmogenic right ventricular cardiomyopathy. Boy, that was a mouthful. It is a rare heart condition where the muscle tissue in the right ventricle is replaced by fibrous or fatty tissue. The epsilon wave represents delayed electrical activation of the right ventricle due to abnormal conduction within the damaged myocardium. Identifying epsilon waves on an EKG can aid in the diagnosis of ARVC. So for follow-up, if you ordered some diagnostic tests, so it will depend on the results, right? So if your stress test, Holter monitor, or your echocardiogram showed abnormal findings, so you're gonna refer your patient to cardiology. But if your Holter monitor showed ventricular rhythm, they have to be evaluated by the emergency because they need prompt evaluation. If your workup is normal, so you can reassure patients and continue to monitor. So I hope this presentation improves your confidence in your ability to care for patients with palpitations. Remember, for metabolic causes of palpitations, as you identified as a result of your workup, such as abnormal TSH or anemia or electrolyte imbalances, you're gonna treat them accordingly. So I'm here as your friend and mentor. If you found this video helpful, please subscribe for more content. And I'm excited to share more videos to support you in your first year of your career. Bye for now.